Good afternoon. And today we have a big honor to interview my friend and very talented artist, musician, and medical doctor, Dr. Dave Mc.Cartny. And
Hello.
we're going to talk about sleep apnea and his book, Empowered Sleep Apnea, and some tools and whole journey, what Dave did to make us all empowered and knowledgeable of this disease in a very artistic way. So good afternoon, Dave.
Hello, it's an honor to be here. Thank you, Maria.
And thank you to all our listeners. We really appreciate, and if you have questions after our interview, please put them in the chat box and we're going to find you the answers. And regarding our community, as you know, my main mission is to bring medical and dental communities together in a search of the answers for treatment for sleep and breathing problems in the same time. And I would like to support people who are going through this therapy and educate them about some adjunct therapies and make them empowered towards the treatment. But also, I would like medical and dental professionals to use our community as a networking grounds, because only together we can bring puzzles of that difficult disease. And today we're going to see some art, what Dave did. And I can go on and on about Dave's resume and about Dave's story. He has really impressive resume with academic background and practical background, but now artistic background as well in the shape of this beautiful book. But my first question to you would be, tell me, what inspired you to write this book? And I'm going to tell a little bit more stories, how we met and what inspired me to invite you here. But I want to know first, what actually happened? Why did you come up with that idea?
Well, it's an interesting project because, as you said, it's kind of not your usual textbook. It's full of cartoons and stories and stuff like that. And the reason I came up with this is at some point in my career, I realized that the fractured nature of our healthcare system is causing harm to our patients. When a patient leaves a doctor's office and goes to an airway-centered dentistry office, they often will have a different vocabulary that they're using to describe the same problem. And the patient ends up getting confused and they won't know how to advocate for themselves. So I wanted to write something that captured the magnificent complexity of this enormous problem. I mean, this is a teeming rainforest of a problem, and it's highly complex. And when the patient doesn't understand the landscape of what they're trying to navigate, they eventually will hurt. So I wanted to give patients the language that they could use to describe this complexity, no matter which provider they went to, whether it was a dentist, an acupuncturist, a doctor, or some other allied profession. They could speak a language that rings true to the complexity of this problem, and they could keep up with their provider. So I wanted to create that empowering message of education for people everywhere.
I think you really did with a full success. And I'm going to tell our story, and I really apologize to our listeners for the little noise we have. But I was actually listening to Dave's speech on Pani, on our Dr. Lambert, who we interview on our channel as well, on his conference. And I was so impressed with the visuals, with the message, of course, but with the visuals. I think, different people take information in a different way. And most of us, a lot of us, take it through the eye. Getting it through the eye make it more understanding, and it's easy to digest. And the complexity of that, it was very successful, and it charmed me on the spot.
Nice.
And
well, it's a very heart-forward message. It's trying to help people understand a level of complexity that's hard to explain in words. So sometimes images can carry a lot more information and help people understand a little bit better.
And this book is full of images, and they made so clear in like they are funny, but alarming at the same time. So that's great. My question to you, since you've been in private practice for so many years, tell us to people who are really interested in the sleep apnea, sleep and breathing at the same time, why sleep apnea need to be treated, why it's so important to use methodology, and then 5 reason monument. I want to bring some words from the book.
Yeah. So the why of sleep apnea is the most important thing that patients can get their hands wrapped around. Why are we treating this? And if we break that why down into its component parts, we come up with 5 reasons. And I decided that this needed a monument. So, as part of this journey, people have to visit the 5 reasons monument, and they have to sit down and they have to actually describe for themselves why we're treating sleep apnea. So this image that's on the screen is the 5th of the 5 reasons: comorbidities, right? If you have other conditions that sleep apnea is known to possibly make worse, and there are thousands of them: hypertension, heart failure, depression, anxiety, ADHD, headaches, irritable bowel. The list goes on and on for comorbidities that can be made worse by sleep apnea. That is one of the reasons to think about treating it, right? If you've got these comorbidities that are possibly being made worse. But going through the 5 reasons, I'm gonna get my hand on the camera, 5 reasons. First reason is risk. And I place that reason as the first reason because risk is the one that's hardest to talk about. Is your case of sleep apnea going to kill you soon if you don't treat it? And this image is risk, right? We've got the guy in each of these images. I fashioned these after a series of woodcuts by a guy who lived a long time ago named Hans Holbein. He did a series of woodcuts called the Dances of Death, or Danse Macabre. And in each of these woodcuts, a skeletal figure is seen as sort of operating as the agent of change. And the idea behind those old woodcuts was, death comes for all of us. It doesn't matter whether you're rich, poor, profane, or pious. Death can come for you, and it levels the playing field. So I use that image. The skeletal figure in these images is sleep apnea, because sleep apnea, it doesn't care if you're fat, thin, old, or young. It can affect everybody, and it can affect every type of person. And so it's something that we need to think about. So why does sleep apnea cause risk? How is that risk understood? These are complex issues, right?
Yes, I like your philosophical approach, and I want to bring that very common thing. I like how you put the mouth.
Oh, yes. So snoring, second reason to treat, right? Do you snore? And if you don't snore, how do you know? Like if maybe you just sleep through it, and a lot of people are unaware of their own snoring. So it's worth exploring. Some people with sleep apnea don't snore at all, right? They can be completely silent. It doesn't mean you don't have the problem. Sometimes the only reason people are aware of their snoring is because when they wake up in the morning, they've got the aftermath, right? They've got that dry throat, or they've got that clogged nose, or the sore throat, right? So sometimes we have to do a little digging to find out if snoring is an actual reason to treat.
Yeah, no, but from my experience, that's what's usually, on a dating site, on a, sexual site, what it's so appealing, snoring become an issue.
Oh, man. Yeah. And snoring is something people are embarrassed about too. And so it's something that they might not want to talk about. They might feel ashamed of it. It might be something that is socially isolating. I've cared for couples who sleep in different rooms because of the snoring.
Yes,
so it separates intimacy.
Or actually, somebody might have so much shame that they don't even want to make a first step.
Yeah. They might not even want to come up and be seen. So second reason to treat is snoring. Third reason to treat, I think you've got this image, is the sleep experience. So if the sleep experience is felt to be problematic, then that can be, sleep apnea can certainly do that. So if people are perceiving difficulty initiating sleep, difficulty maintaining sleep, frequent awakenings, frequent trips to go to the bathroom, early terminal awakenings, all of these things that can be categorized as part of the sleep experience can be messed up by sleep apnea. So in this image, we see sleep apnea is there ready to crash the cymbals and disturb this poor guy's sleep, who's obviously having some trouble breathing there.
Yeah, and they're so, into your face, those images. That's what actually charmed me when I saw your lecture on the screen, the images.
Yeah.
I would like to ask you now a question from your practical life.
Can we finish we didn't get through the 5 reasons. I feel like our
yes. Let's do 5
viewers
reasons. Yes.
So we've got risk, we got snoring, we've got sleep, then we've got wake. Wake is the 4th
let's
reason.
do wake.
So let's look at the wake image. The wake experience is often problematic for people with sleep apnea, but it varies. Some people feel excessively sleepy. Some people just feel brain fog. Some people feel irritable and excitable because their sympathetic nervous system is so riled up. So if, exploring what the wake experience is like has many different levels. And I think one of the things that people kind of forget about is they say, well, I'm not falling asleep, during the daytime, so I can't have sleep apnea. And that's only part of the spectrum of what this can do to the waking experience. So it's worthy to sit down and inventory it with ourselves and with our providers to talk about that. And then we've already talked about the 5th reason to treat, which is the comorbidities. And we've shown that.
I want to bring it back for people to see.
So here we've got some poor soul. The name of this cartoon character is Claudio. He's somebody I made up when I was an undergraduate, and I had a comic strip for the school newspaper. So Claudio has come back to life, and he's been helping me tell this story. But in that image, you can see he's dragging this mine car full of medicines and prescriptions, and it's labeled with all my afflictions. And there the happy skeletal figure is just riding along, having a blast. And the Latin on his little flag, if you can bring it up, says, it says labor or die. Basically he has to keep working to keep his insurance, to keep on going, to keep with all his medications. He's got to keep climbing up this hill or else he's going to die,
And then that's not easy. I see he's suffering through the screen.
Yeah, he's suffering, and it's a long road. You can see it's 12 miles to get to his doctor's office, all uphill. So this is the burden that people experience. And a lot of folks just kind of go through their lives with their blood pressure and their migraines and their fibromyalgia and their irritable bowel and their reflux and their asthma and their sinus infections. And they don't realize that they're all connected, right? They're all connected by a common source.
The beauty of it. For me, I see all these dots every day, and I have to explain to people, yes, it's part of the story.
It's part of the whole shebang.
That's also affecting the treatment. If we don't cooperate, different communities don't get together and find something, common language what we can speak. But you did a really good job explaining it in your book.
Yeah. And anybody, and you can take those 5 reasons to treat to anybody, right? A patient can say, listen, I'm going to see my dentist because the CPAP isn't working out for me. And then I can say, great, make sure you go over your 5 reasons to treat and make sure you're following those reasons and you make goals out of those reasons so you know when we're getting there. Because I think what people might encounter when they go into a specific siloed of thought, whether it's a dentist or a doctor's office, they might find that it gets simplified. And that the label sleep apnea means, oh, well, we need to treat that because, and then usually the blank that's filled in, sleep apnea will shorten your life if you don't. And so it becomes almost a threat. And people start to avoid treatment when they feel threatened like that. So being able to break it apart and say, well, I've discussed the risk aspect of this, and this isn't the type of sleep apnea that's all that risky. So really the goals that are important to me are my sleep experience, my snoring, and my wake experience. I don't have any comorbidities right now. And then the dentist or the doctor can say, okay, I know what we're working on. Let's see if we can work on those 3 aspects of this and see if we can get you any closer to, Pleasant Dreams Beach.
Pleasant Dream Beach. Yes, I don't have that picture, but I have it in the book. Yes. I really like your island. For some reason, I cannot bring it up. But maybe
you can maybe show the image from the book.
Maybe I can show image from the book. Yeah, the island was great. I'm gonna find it and I show the island. I like how it made through the journey, but we all go through the journey and we all have to get to happy destination, hopefully.
Yes.
As soon
That's
as
what
possible.
we all want. We all want to go to the Pleasant Dreams Beach at Happy Z's Sheep Counting Ranch and Country Bistro.
Yes. Now, I would like to ask you, how did you accomplish? I know there's something what amazed me during your lecture, during your talk, what working with your patients and empowering them you made the compliance for CPAP machine from 50%, which is normal around the country, to 90%. Tell me, how did you accomplish that?
This is a true story, and this is the part that a lot of people have trouble believing. But in our system, when I was working at Colorado Sleep Institute, we took care of all of our own DME, durable medical equipment, in-house. And for those that, for insurance reasons, we had to send them out of house, we would still get access to their download data. And so I had 24/7 access to everybody's data, and it was really on an intention to treat sort of format. We knew whoever we started, we knew how long they stayed on it, and we knew when they stopped it. So I had long-term data for everybody. And honestly, my long-term compliance, long-term in my clinic, was over 90%. And that's by Medicare standards. But usually people, when they were compliant, they were using the device for 6 or 7 hours a night. It was unusual for me to have patients that would only get 4 hours. And so having said that, why is the question? Why were these patients so good? Were they somehow unusual? Were they just unusually committed? And, every clinic is sort of beset with this self-selection rule, right? People choose to go there. And so we can take a look at who these people were. And most of them, a lot of my patients had been sort of forgotten about and had abandoned CPAP therapy in the past. And they'd come back basically because someone told them that, here's a provider who's going to listen to you and talk you through the process. So I will say that the short answer to why the compliance rate was so good had nothing to do with like magic of CPAP, had nothing to do with magic of me as a provider. It had everything to do with the patients understood their 5 reasons. So they were empowered to understand why we were doing this. And they were empowered to understand that the CPAP machine can be altered in ways that can enhance their ability to meet their goals. Most importantly, we did a lot of pressure explorations to make sure the device was not too aggressive. A lot of what I found is over titration of CPAP due to the fractionating system. A doctor would write an order for CPAP, send the patient to an outside DME company, and then the device would be initiated using a very wide pressure range. And ultimately, it ends up being on too high of a pressure, which forces air out of the mouth. And then the device would have the mask change to the full oronasal mask. And then before you know it, you've got a really unhappy patient. And the missing piece of this puzzle is that many providers don't see any of that because that's not happening in their office. That happens someplace else. And all they know is that the person stopped coming to clinic,
So the people just shade the weight when they're not hurt.
Yeah. And so they just stop coming to the clinic, or they don't go back. And the provider just says, well, boy, it's a rough world. We've got this terrible 50% compliance problem. And really what the problem was is our system was fragmented, and the right hand didn't really know what the left hand was doing, and the patient didn't know either. So I found that by empowering the patient with knowledge that gives them agency, in order to sort of know what we're trying to accomplish and know what the tools are and what the limitations are, the patient was able to act as my personal agent of recovery, And that's an important distinction, this idea that we can collaborate together. It's not a top-down, I'm going to tell you what to do and you're going to do it. It's more of a, hey, let's look around this big cave and I'm going to tell you all the features, and then we're going to find our way through this cave together. That's real empowerment. That's collaborative care.
I agree with you 100%. That's nice, when you can do things together.
Yeah.
I would like to ask you, medical and dental community, and you work with both of us. So tell me, what difference in our view on sleep apnea?
Oh, it's evolved to be completely different. So when sleep apnea was first described, we've got to go back to the 60s and understand that this hasn't always been an entity that we've known about. Before 1966, we didn't even know that sleep apnea existed because the study wasn't done. Nobody thought to take a person who, at that time, we called it Pickwickian syndrome. We knew that heavy snoring people were tired and were sleepy during the day. So we had this idea, and we also knew that heavy snoring people who were sleepy tended to die young of things like pulmonary hypertension and heart failure. Okay, so it was a reasonable thing to try and start scratching our heads about. Pickwickian syndrome was dangerous. So in 1966, a French epileptologist named Henri Gastaut decided to do a sleep study on a person with Pickwickian syndrome. And what he found was that this person was stopping breathing in his sleep. And so all of a sudden we had this new concept. There's this thing called sleep apnea. Now, nobody did anything about it back then, at least most nobody did anything, because the only solution was, well, you got to lose weight. So that's what they told people. They told heavy people who were snoring and sleepy, they told them to lose weight. And they said, if you really want a fail-safe option, we can poke a hole in your neck and you can breathe around that obstruction. That's called a tracheostomy, and that's highly problematic. But, for some people, it was better than dying young. And that's the way it was managed up until about 1980, when a man named Colin Sullivan in Australia decided he was going to start cobbling together parts of a paint compressor and and non-invasive ventilation equipment, and he created something called nasal CPAP. And all of a sudden, we had an option for Pickwickian patients that was different than a hole in the neck. We had this device that could blow air into your airway. Okay.
Yeah, that was a magnificent thing. What you have.
I mean, all of a sudden, yeah, we have this great new tool, and so Pickwickian patients around the world rejoiced that they had something that can help them sleep and help them breathe. But what happened after we created this label called sleep apnea is we had to define what it was. So we started looking at sleep studies, and we realized that there are types of events that can be scored. And the more we did this, the more we realized that a lot of people who didn't fit the Pickwickian phenotype were scoring positive for sleep apnea, okay? With more subtle events, maybe events that don't cause oxygen to drop, and maybe these people weren't even heavy, and maybe they didn't even snore, okay?
That's the people who dental community
and
sees.
That's who the dental community sees.
Different patients.
And I think some of this is self-selected, Maria, because the people that dentists see, it's a different phenotype. If the Pickwickian phenotype, it's called Pickwickian, by the way, because of Charles Dickens.
I know, absolutely. I love the story of that little boy.
Yeah, the listeners may not know this, but the posthumous papers of the Pickwick Club is the first novel that was written by Charles Dickens. This is back in the 18-somethings. And in this novel, it's a series of adventures of these rich boys in a club that they called themselves the Pickwick Club. And in the story, there's a recurring character named Joe. Sometimes he's called Fat Joe because he was an obese young man. And he makes his introduction in the novel by literally falling asleep on his feet. So he's knocking at the door, and as he's knocking, he's falling asleep and he's snoring while he's knocking at the door. So it was light comedy at the time, but the great Dr. Osler, who was the first chair of medicine at Hopkins, which is arguably our first modern medical institution in this country, Osler made the acknowledgement that heavy people tend to be kind of sleepy. And he said, not unlike the boy in the Pickwick Club. We're going to have to edit this. My phone is going off and I can't find it. So I'm just going to say, can we edit this part out later? I'm sorry, my phone's dinging and I don't even know where I left it. So I'm going to have to just...
I don't hear this. It's not, it's not registering it. Thank you very much. That's a wonderful answer. So we see totally different from medical and dental.
I'm so sorry to interrupt that story. So yeah, so Fat Joe was the first starting point. And the people that are going to dentist office are often thinner, they're often female, and they often don't snore, and they're usually not sleepy. So they present very differently. But if you did a sleep study on them, they would still have that label sleep apnea. These people almost intuitively avoid going to see a standard sleep doctor like me because they know about CPAP. And
they don't want. They usually look really good, and they don't want to have.
They don't want to, and their sympathetic nervous system tends to be overdriven. So these patients tend to present with insomnia rather than hypersomnolence. And so that try putting a CPAP machine on someone like that. It's almost like they're allergic to it. So what we've seen is a sort of an evolutionary divergence of where the patients go, and so the dental community sees this problem called sleep apnea very, very differently than the medical community does, because the patients self-select. And that's an important concept for why these silos of thought need to communicate more, because we need to learn from one another.
That's exactly what we're doing. Thank you very much, David. It was so wonderful. It's such a wonderful revelation. And I think talking to you and seeing your work, it gives me hope what one day we can communicate and share our knowledge, because yes, our views are totally different.
And cross collaboration is going to be the future of this disease. No one silo of thought has got this right. So the only way for us to really help our patients navigate is for the different silos of thought to get our heads together and actually openly, collaborate and communicate, both as a strategic idea. So, at the upper levels, the thought leaders need to communicate, but also on an individual basis. We have to understand that the patient's journey is fluid and isn't always going to be remaining in one single silo of thought. And we have to help them navigate that landscape.
I like it. And unfortunately, I cannot show the map, but the map helped them navigate. I have it on my screen, but I cannot bring. But thank you very much, David. We're really looking forward to continue this conversation. And, we recommend everybody to get on your website, Empowered Sleep Apnea, and read your beautiful book.
There it is.
And listen to the podcast. And you're going to get really empowered. Thank you.
Empowerment saves. Don't forget, empowerment.